the recording. Okay. Hello, everyone. My name is Emalie Robson. I use she, her pronouns, and I am the Transformation and Community Partnership Manager at the Foundation of Healthcare Quality. I also work primarily with our BREE collaborative. I use she, her pronouns, and currently I'm speaking from the unceded land of the Duwamish tribe. We acknowledge the Native people, past, future, and present, who have cultivated the land within Washington State, their knowledge and practices that support the health of people, animals, plants, and land in our area. As we begin our webinar today on the BREE recommendation spotlight on hepatitis C virus, we wanted to go over some housekeeping items. As you've logged in, you have been placed on mute upon entering. Later in the presentation, we will have a portion for question and answers with our presenters. If you have any questions, please place them in the Q&A box at the bottom of your screen, and we will get to them later in the presentation. As we mentioned, we will have a recording of this webinar that you can view after the webinar is completed, and we plan to post it on our YouTube channel for the Foundation of Healthcare Quality. Additionally, we do have a slide deck for today that we will plan to send out via email, so please look out for that. As a background, we just wanted to highlight that the Foundation for Healthcare Quality has a total of 6 different programs, and the BREE Collaborative is just housed under the Foundation of Healthcare Quality. It was created in 2011 by legislation to bring together members from different areas of the healthcare sector to address key health topics that impact Washingtonians by being a place for convening and collaboration. This is an example of our roadmap to health ecosystem improvement. On the bottom of the screen, you can see the different areas within the healthcare ecosystem of where we collaborate with different partners to create clinical topics that can then be implemented into our health ecosystem to support healthcare quality, outcomes, affordability, and equity. Since the creation of the BREE Collaborative, we now have 40+ reports. And recently, this upcoming year, we're going to be focusing on diabetes care, maternal mental health, and difficult to discharge clients. We were fortunate enough this past year in 2022 to work on this hepatitis C virus, and we're really excited to have some of our speakers present to you who are members of our work group. We will have individuals from the DOH, such as John Stockton and Emalie Huriaux. We have Dr. Judith Tsui from the University of Washington, and we have a pharmacist, Wendy Wong from Providence, to speak with you. So I'll pass it over to John and Emalie.
Great, thank you so much for the great introduction. Hi everybody, my name is John Stockton. I am the Adult Viral Hepatitis Prevention Coordinator here in the Office of Infectious Disease at Washington State Department of Health. And I'm going to be going over a bit about the background around hepatitis C in Washington State and currently what we're seeing. Next slide. So the agenda for myself and Emalie, I will be doing a quick overview, a very high level overview of hepatitis C and overall burden that we're experiencing in Washington State. Emalie will talk a little bit about the Washington State Elimination Plan that we've been working on for quite some time. Some of the BREE collaborative planning efforts that we went, and also some of the recommendations that came from that report. Next slide. So hepatitis C, just to provide some very kind of high level background about this virus. So hepatitis C is the most common bloodborne virus in the United States, estimated about 2.4 million people impacted, and those are estimates by CDC back in 2018. The virus itself actually was not identified until 1988, and reliable tests to detect the virus didn't come about until several years after. It's often asymptomatic, so when people come into contact with hepatitis C, it can be years and sometimes even decades before people know that they have it. For some that become infected, for about 1 in 5 individuals, spontaneous clearance can happen. So roughly about 20% of those individuals, their body can clear the virus. Unfortunately, that's not the case for most individuals, and about 80% go on to become chronically infected. Most people who do go on to develop chronic infection can really can be lifelong if untreated and cause some serious health issues like liver damage. Liver failure and is the most common reason, continues to be the most common reason for liver transplantation in the United States. Transmission, it's blood-to-blood contact. Most common mode of transmission is sharing drug injection equipment. Less common is natal transmission, so onward transmission from mother to baby, unprotected sex, needle stick injuries in healthcare settings, and also unregulated tattoos and piercings. The good news about hepatitis C, though, is in the last several years, new medications, now we actually have a cure for hepatitis C, which is pretty profound. Prior to the new direct-acting antivirals that became and made available to the population, we had some past treatments for hepatitis C that was pretty low outcomes for health. They had a lot of side effects and really were really not something that most folks could tolerate with pegylated interferon and ribavirin treatments in the past. The one big thing about hepatitis C is that there is no vaccine like there is for A and B. So that's something something that we always need to go over, because a lot of times folks think that hepatitis C there's a vaccine for, which there is not. Next slide. So one of the questions when we start talking about Hep C surveillance in Washington State that a lot of people have is just, well, how many people are impacted by hepatitis C in Washington State? And that's actually, unfortunately, a really tough number to calculate within our state. Hepatitis C did become mandated reportable in 2000 for healthcare systems, healthcare providers, and also laboratories that must report hepatitis C infection to their local health jurisdiction. And unfortunately, we don't receive a lot of those reports. So trying to calculate prevalence numbers becomes that much more difficult to do. Also, we do have some limitations with our surveillance system. We're right now not able to accurately track the number of individuals that move out of state, who have been cured, or who have passed away. So coming up with a prevalence number is a little difficult to do. I would say the primary barrier to calculate that number really has to do with those case reports and making sure that providers do send those into their local health jurisdictions. However, back in 2018, we were able to receive a small pot of funding to work with the Center for Disease Analysis, which is a contractor that does a lot of surveillance modeling for states. And we were able to come up with a prevalence number for the state using very large data sets such as Medicaid data, all payers claims database, our own surveillance registry, and other large health jurisdiction registries. And the number that they came up with was roughly about 59,000 folks within Washington State are thought to have hepatitis C in our state. And of course, you have to take that number with a little bit of grain of salt when you see the range there for that prevalence number. It can range from anywhere from 32,000 to 71,000. So again, 59,000 is just a very, very rough estimate. As you can see on the right-hand side, you can see the number of cases that were reported to the state from 2012 to 2021. As you notice, from 2012 to about 2017, we saw a dramatic rise in the number of cases for hepatitis C within our state. And that could be due to a whole lot of things. There are new screening recommendations. There's just more general awareness of hepatitis C. We now have a cure. And also, this is also points to the rising opioid epidemic and those who inject drugs. And so in 2017, of course, we had 8,800 as the highest number of cases. In 2018, in the later part of 2018, this is when COVID hit. So as you can see, the number of overall cases that have been reported to the state have dramatically dropped off. And this is true of all health conditions within our office. So things like HIV and STIs, the number of cases also dropped as well during COVID. Next slide. So, oh, there we go. So this is just to take a look at the overall burden within the state. Take special note, this is back in 2019, so this is right around pre-pandemic levels. So this is just taking a look at overall case and rates for each of the county within our state. Hepatitis C is very unique in that it doesn't really, when it comes to rates, doesn't follow population density as other conditions do, like HIV does. One of the things that's really important to note when just taking a look at rates is that for hepatitis C, absolutely impacts rural communities, which makes our job a little bit tougher to do when there's not as many resources that are available to those that are impacted by hepatitis C. Next slide. So this is age distribution. We've seen a very noticeable age distribution of those impacted by hepatitis C among chronic cases within our state. And so what you're seeing here is on the left-hand side, back in 2007, and then another snapshot in 2019. So about a 12-year span there, taking a look at just age distribution among cases. So back in 2007, the most heavily impacted age group within our state were those who were born between 1946 and 1964, also commonly referred to as the baby boomer population. Fast forward to 2019, what we've seen is we've seen a noticeable shift in the age demographics when it takes a look at Hep C. So we've seen the number of the baby boom population overall cases drop, and the number of young folks, particularly those 31 years and younger, are the most heavily impacted now within the state. And again, this points to the opioid epidemic that we're currently experiencing in the Washington state, and of course, the rise of injection drug use. Next slide. And this is just to take a look again, a little bit different. So this is age distribution in 2021 and also gender and sex. And as you note, those 31 years and younger continue to rise, but this is just showing this just a little bit different. Of course, male versus female, males are typically more impacted by hepatitis C, but this is just another way to take a look at those numbers. Next slide. So this is a care cascade for hepatitis C. Again, this was done in partnership with CDA Foundation, so Center for Disease and Analysis Foundation. And this is taking a look at, for Washington State, using, again, very large data sets to kind of model what a care cascade looks like within Washington State. On the left-hand side, so the red bar indicates how many people that we believe to be impacted by Hep C, so roughly about 59,000. For those who have already been diagnosed, we believe there's already about 88% of those individuals that have been identified, so they know their status. Where things start to drop off really is the yellow bar there, is that the number of those individuals who know they have Hep C that actually get linked into care and supportive services, there's a dramatic drop off. And this is where we spend a lot of our time in programming, trying to really scale programming up and systems up to actually get people from point A to point B. So if somebody knows they have Hep C, linking them into care and supportive services is the most important thing to do, so they have access to curative treatment. But it's that process of getting people from point A to point B that is really, really challenging within our state. So as you see, only about 12% of those who know their status actually initiated treatment. For those who initiated treatment and completed treatment, 95% of those individuals became cured. So we know that the new drugs do work. Again, it's really what those systems look like and what is the programming to get those individuals linked into care and supportive services more efficiently. Next slide. And now I'm going to hand this over to Emalie Huriaux, who's going to talk a little bit about our Hep C elimination efforts within our state and also the BREE collaborative work.
Great, thanks, John. I'm Emalie Huriaux. I work with John at the Department of Health in the Office of Infectious Disease and manage a section in our office that works on integrated infectious disease testing, hepatitis C, and then our programs to support the health of people who use drugs, which includes work with syringe service programs around the state and administration of the statewide overdose education and naloxone distribution program. So I'm going to talk a little bit about sort of the so what. So we have all this information about the impact of hepatitis C in Washington, what's been done about it to date, and then apologies, the dog is barking, of course. What we've done about it so far and sort of where we're heading with the BREE recommendations. So back in September of 2018, Governor Inslee issued a directive to eliminate hepatitis C in Washington state. And there was a press conference at Harborview. You can see some of the images. Some folks may recognize some of these faces. Scott Lindquist, the state epidemiologist, John Scott from the University of Washington, Jeff Duchin from Public Health Seattle King County, and the governor, of course, and Michael Ninberg, who was the former executive director of Hepatitis Education Project. got together to bring forward this directive. And next slide, I can talk about what that directive sort of told us to do as state agencies. So it asked Healthcare Authority and Department of Health to jointly develop strategies to eliminate hepatitis C by 2030. And I'll say that this is also, this 2030 date comes from the World Health Organization's International Hepatitis C Elimination Initiative. So that's sort of the eye on the prize is the year 2030, both kind of for our local initiative, but for other initiatives throughout the country and throughout the world. A specific directive went to Healthcare Authority to develop a procurement strategy for those direct acting antivirals that John mentioned for all state covered lives. And that includes Medicaid, the public employee benefits and school employee benefits, the state hospitals, Eastern and Western State Hospital, the prison system, and L&I, the sort of workers coverage, workers compensation. And then it directed us specifically to look at DOH to develop a multi-sector stakeholder group and develop a public health outreach strategy. Next slide. So for Healthcare Authority, for the purchasing strategy, they issued an RFP in early 2019, and that was to request discounted drug costs for all state covered lives, as well as outreach support services. And the proposal that rose to the top came from AbbVie Pharmaceuticals. And so they entered into 2 agreements with them that started in July of 2019. One was a Medicaid agreement, which also describes some of the outreach services AbbVie helps coordinate. It includes a statewide hepatitis C elimination bus that goes to various events and provides hepatitis C testing and linkage to care services. And then there's an agreement for the non-Medicaid state covered lives that includes the programs like the prisons, public employees, school employees, et cetera. So 2 separate agreements to get really try to get the lowest cost possible on the medication Mavorite, which is a direct acting antiviral that is effective for most people living with hepatitis C. Next slide, please. So it really, you might hear it called the Netflix model, the Medicaid agreement, but really what it is a modified subscription model. It's different from Netflix in that when I pay for Netflix every month, I can watch an unlimited amount of shows, TV shows and movies. In this model, there's a guaranteed net unit price for the medications, but after a certain threshold treatment goal is met, the drug cost above that threshold becomes negligible. So that is sort of a modification of what you might think of as a Netflix model. It's not exactly apples to apples. And then the non-Medicaid agreement really is a rebate agreement, sort of a traditional rebate agreement that those of you who are familiar with pharmaceutical purchasing might be familiar with. It does allow an option for Department of Corrections to pursue 340B pricing. And it also includes an option to potentially expand to other purchasers, though at this point that hasn't been entertained as far as I understand. Next slide. And so at the DOH level, we brought together a variety of stakeholders to develop an elimination plan, which was released in July of 2019. There were 15 goals and 90 recommendations. Again, I apologize for the dog. The plan, the group has really looked at the plan in the last year or so and whittled down to 7 priorities that are really the focus for the coming years. And so you can see more about that on the link that's posted below. And some of the things that really make elimination possible in our state is we have good access to syringe service programs, which is really important for prevention of hepatitis C among people who use drugs. We also have increasing and improving access to medications for opioid use disorder, like buprenorphine and methadone. Also really a critical component of a foundation of prevention for hepatitis C. And then we have some really committed medical providers working to treat and cure hepatitis C. We have some great academic institutions with clinicians and educators studying Hep C interventions and building provider capacity, and some specific resources that exist in the state is the viral hepatitis echo program run out of University of Washington, as well as the Hep C online curriculum that really allows providers to do self-directed education if they want to improve their skills on Hep C treatment. We also have Medicaid expansion, which is really critical to make sure that we can treat people who qualify for the Medicaid program and who are living with hepatitis C. Our AIDS drug assistance program supports Hep C treatment for people who are living with HIV and hepatitis C. Not all state ADA programs support Hep C treatment, so this is really valuable for people who are co-infected. While we don't have the same level of surveillance and assessment as something like HIV does, just because of resource limitations, our surveillance and assessment efforts are improving. And we've had some CDC support for our programming and surveillance, which has been a helpful foundation. Next slide. I think some challenges we're really seeing are increasing homelessness and displacement. That makes it really hard to both sort of track people and keep folks engaged in care, but also when folks are competing with life domain issues with social determinants of health challenges, Hep C may be really low on their priority list of the things they need and want to address in a specific month or year. And so that I think really makes the proposition before us challenging. And also, as John pointed out, this increased incidence of Hep C among younger people, particularly young people who inject drugs, because Hep C can be asymptomatic or have sort of non-specific symptoms of fatigue. The sort of medical necessity of getting treated may not be as relevant for someone who's feeling fine, who's maybe also dealing with some other life domain issues. And young people, maybe traveling, maybe more transient than older folks. And so I think that makes sort of the linkage to care and care coordination piece challenging. Also with our case reporting, we're missing a lot of information about race and ethnicity in our case reports. And so it's really hard to define sort of racial disparities, have a really clear path towards improving health equity. We can make some assumptions based on national data and the data we do get, as well as information we've gotten from our partners at places like the Northwest Portland Area Indian Health Board that really show disparities in outcomes for Hep C for people who are Native American and Alaska Native. But that's an area where improved data submission would be really valuable. And then while we have some really fabulous providers treating Hep C, we're still really challenged by many primary care providers who aren't yet ready or willing to treat hepatitis C in their practices, or some that will treat hepatitis C but will not treat people who use drugs. And so those are some areas we would love to see improved access to care around the state. And then there really is limited federal investment in viral hepatitis surveillance, prevention, testing, and treatment interventions. And that's really a national challenge. It's not unique to our state, but one that we contend with is just, what resources are available to bring to bear to address this issue. And so just pivoting to sort of what we've done with the BRIE collaborative, pulled together the hepatitis C specific group that included folks from local health jurisdictions, folks from state agencies, clinicians, managed care organizations, community-based organizations, and health plans, and really looked at how to align the BRIE recommendations around hepatitis C with the current Hep C Free Washington efforts so that this would be sort of a value add instead of redundant of, and prioritized kind of concordant to this, our Hep C Free Washington Coordinating Committee worked to prioritize our elimination recommendations for the next coming years based on impact and feasibility. And then the BRIE Collaborative Hep C Work Group worked to address those existing recommendations, specifically as they relate to sort of healthcare delivery systems. Next slide. So I won't read this in great detail, but some of the areas we focused on were metrics and how to look at maybe some specific metrics in value-based contracting, how to encourage increased screening and treatment for hepatitis C. Care coordination and expanding treatment access was a large part of our conversation, and really trying to figure out how to address barriers to care and really improve that care cascade or cure cascade that John showed you earlier. We really need that yellow bar to meet the previous bars and then get the sort of treatment and cure rates to rise subsequently. We also talked a lot about how to embed hepatitis C services, both testing and treatment, outside of the walls of traditional clinical settings, because there are many people that are not well served by brick and mortar sites or sort of traditional business hour services, and really need low barrier access to care. And sort of related to that, how to use non-traditional models, expanding testing and treatment opportunities for pharmacists, looking at the opportunities telemedicine might provide, and then how to sort of innovate with contracts and reimbursement to increase availability of Hep C treatment. And then lastly, really engaging providers to ensure prescribers are comfortable and willing to provide Hep C care and treatment in their communities. And I believe that was the last piece for me at the moment. So thank you so much. And again, really apologize about the dog.
Thank you, Emalie. We will now pass it over to Dr. Tsui.
Hi, everyone. Thank you for this opportunity to speak with you today about the BRIE recommendations for clinicians. So a little bit about me. I'm an internist and a primary care doctor who's been involved in treating hepatitis C since the early 2000s. I'm currently a physician researcher at the University of Washington, working at Harborview Medical Center. And a disclosure, my research is funded by NIH, but of course the views expressed here are my own. Next slide. So the work that has been done by the BRIE Collaborative is grounded in the mission of improving patients' lives. And so for this reason, I'd like to start with a patient vignette to remind us of the real world context for this work. So this is a fictional case that is based on real patients that I've seen over time. TS is a 38-year-old woman presenting for primary care. She has a history of alcohol and cannabis use as a teenager. She experienced a back injury in her late 20s, which introduced her to prescription opioids. She took those on and off for years, after which she initially transitioned to intranasal heroin, but started injecting drugs in her early 30s and now uses or has used heroin and methamphetamine. So she's recently initiated treatment with buprenorphine 6 months ago and is doing well. She had screened positive for hepatitis C years ago at a syringe service program, and it was confirmed that she had a chronic infection with a subsequent pregnancy. After delivery, she was referred to specialists for treatment, but missed her appointment. And as such, she has never received treatment for hepatitis C. Next slide. So after hearing this vignette, there are some questions that I'd like you to contemplate. Why is TS still living with hepatitis C? How many opportunities were missed to treat and cure her? What are the risks to her own health if she remains untreated? What are the risks to her family and community if she remains untreated? How many additional people have become infected because she was not treated when initially diagnosed? And what is the burden of cost to our healthcare systems that have accumulated because she has not been treated to date? Next slide. So to start with the question of what are the risks to her health by not treating her. So if untreated, approximately 1/5 of patients will develop cirrhosis within a few decades. And once an individual has cirrhosis, there is risk for liver cancer, liver failure, and death. And how quickly an individual progresses to these complications can depend on a number of factors, including alcohol use. It is worth noting that since 2007, hepatitis C has actually exceeded HIV as a cause of death in the US. Next slide. But there are many other additional benefits to treating hepatitis C other than just reducing liver complications. So it's important to note that hepatitis C is a chronic viral infection, which is accompanied by sustained inflammatory responses, much like HIV, that can potentially impact many different organ systems, including kidneys, heart, and brain. And as such, curing hepatitis C may reduce other disease risks as well. Also, the experience of living with hepatitis C, which is a highly stigmatized condition, can cause shame and distress. Also, there's a public health benefit to reduce transmission to other individuals. By treating and curing individuals who are transmitting hepatitis C, we may interrupt new infections and reduce disease burden over time, a concept known as treatment as prevention. So this paradigm may be unintuitive for some clinicians. For example, when evaluating a young person who's actively injecting drugs, the temptation might be to think this person is not at risk for immediate hep C complications, therefore there's no urgency to treat. That may be true from a patient perspective, but from a public health perspective, there's a strong urgency to treat as it will help prevent new infections. Next slide. And treatment for hepatitis C has never been easier. So this slide highlights how radically different the treatment looks today compared to the prior era with interferon and ribavirin. Previously, treatment was lengthy. Most patients experienced serious debilitating side effects. And at the end of the day, only about half of patients got cured. Now with the pan-genotypic DAs, nearly all patients can be cured with just 2 to 3 months of all oral treatment with few side effects. Furthermore, recent evidence suggests that medications are so effective that even with imperfect adherence, most patients will be cured. Another thing to note is that while early on DA regimens were more complicated, with some being genotype specific and requiring resistance testing, we've reached a point now where things are much simplified with the choice of basically just 2 panogenotypic meds. Next slide. Thus, the newest clinical guidelines recommend screening all adults for hepatitis C and treating anyone who's infected. So in 2020, the US Preventative Services Task Force revised its guidance to recommend hepatitis C screening to all asymptomatic adults ages 18 to 79. Previously, it recommended screening baby boomers and those with risk factors only. Ideally, screening with an antibody test is followed by a reflexive confirmatory RNA test so that there's no wasted time needed for a second blood draw. Next slide. So the Infectious Disease and Liver Specialist Professional Society guidelines recommend treating all persons with hepatitis C regardless of substance use. And in fact, the guidelines draw attention that treating persons who are actively using drugs is critical for achieving hepatitis C elimination goals. Next slide. As a clinician, I feel incredibly fortunate to practice in a state where medications for hepatitis C are readily available for my patients. And so, as mentioned earlier, prior authorization is no longer needed and any licensed prescriber can treat for hepatitis C. Next slide. And this approach is backed up by studies that have demonstrated equivalent cure rates comparing non-specialist to specialist treaters for uncomplicated patients. But for patients with advanced liver disease or certain other conditions, treatment is more complicated and should be offered either by or in consultation with specialists. Next slide. So this slide lists some of my personal reasons why I find it very fulfilling to treat hepatitis C as a primary care and addiction provider. Number one, it's rare to cure a chronic viral infection. As a primary care provider, we do a lot of chronic disease management and don't often get the chance to cure a disease. Number two, it leads to the health and well-being of patients and their communities. Number 3, it's a treatment that patients are eager to receive when they're made available. And in my experience, patients are extremely grateful, and it goes a long way to building trusted relationships. Number 4, it's relatively easy to do. I would say a lot easier to do than other conditions that we're expected to manage as a primary care provider. And number 5, it appeals to clinicians' altruism, I believe. You can feel good about contributing to state, national, and global public health goals. Next slide. So you might wonder, why don't more primary care clinicians treat hepatitis C? So these are some of the barriers that exist. Number 1, there may be some clinicians that are, as of yet, still unaware of new DA medications and simplified guidelines for treating hepatitis C. Even if aware of these new medications, they may not be aware of the lifting of restrictions that were formerly barriers, such as the lifting of requirements for prior authorization, specialist consultation, etc. Some clinicians may feel ill-equipped to treat hepatitis C without more education and training opportunities. And even after receiving training and education, they may lack institutional support and incentivization to treat hepatitis C. And finally, there can be, I think, fears of failure and also attracting the wrong sort of patient. We do know that provider biases and stigma are real. Next slide. So the BRIE recommendations seek to address these clinician barriers. And here are some of the recommendations that specifically impact clinicians. Number 1, it recommends to develop and incorporate hepatitis C metrics into value-based contracts. As we know, this is really what drives clinician priorities in care. As a primary care physician, I can attest to all of the pressures that I have to order screening mammograms, to order hemoglobin A1C for diabetes care. Currently, none of that exists for hepatitis C. It recommends to expand care coordination services with things like peers, patient navigators, case managers, to make it easier for clinicians to complete diagnostic workups and offer treatment. It promotes community-based care models and thus encourages healthcare providers and systems to expand care outside of traditional hospital and clinic settings. It encourages the use of collaborative drug therapy agreements and partnerships with pharmacists and physicians, thus leveraging pharmacist expertise and expanding the workforce of treaters. It recommends to ensure adequate training and support for learning to treat hepatitis C for all providers, including primary care providers. And finally, it recommends to reward clinical teams that seek to address disparities in hepatitis C treatment, such as for homeless patients, racial minorities, and people who actively use drugs. Next slide. So finally, with this slide, I'd like to remind clinicians that there is an abundance of resources available for training and support for those who are interested in treating hepatitis C, including professional society guidelines, online trainings, Project ECHO, a real-life phone consultation through UCSF, and online medication interaction checkers. And finally, encourage clinicians to also lean upon their pharmacist colleagues. And with that, I think I'll turn things over to pharmacist Wendy Wong. Thank you.
Thanks, Dr. Tsui. Hi, everyone. Thanks for this opportunity to speak. Next slide. My name is Wendy Wong, and I am the Hep C pharmacist at Providence Centralia Hospital. I started working at the Healthcare Authority around the time that the first direct-acting antivirals came on the market. The next few years were a heady, exciting time with new changes and updated guidelines every few weeks. When the changes slowed down, I moved over to Providence to lead their new hepatitis C pharmacotherapy service. In all, I have reviewed or worked up almost 10,000 Hep C cases. I have a knack for convincing reluctant Hep C patients to get treated, as well as convincing anti-vaxxers to get vaccinated. But what I enjoy most is training new Hep C providers. Next slide. People at the greatest risk of Hep C infections are those between 18 and 39 years of age and those who use injection drugs. From a clinical perspective, these are the easiest patients to evaluate for treatment. Most of them will not have cirrhosis or complicated drug interactions. Next slide. Pharmacists are the most accessible healthcare professional. We are in every town and are available more hours than any other non-urgent care provider. We are more approachable than any other provider. We can and are called upon to play a role in Hep C elimination in Washington. There is so much to be done that we can choose to do as little as possible and still contribute to Hep C elimination. But choosing to do nothing is no longer acceptable if we are to eliminate this completely curable disease. Vaccinations in pharmacies didn't used to be a thing. Safeway made it a thing. Hep C screening in pharmacies isn't yet a thing, but it can be. We just need a pharmacy chain to take the lead, then other chains will follow. A patient advocate from my hometown said, expanding access to screening through pharmacies will help improve access to treatment and curative therapy and erode the stigma associated with the disease. Chain pharmacies have the resources to promote Hep C screening and treatment. They have posters and banners, store coupons, and large networks. Insurances pay for COVID tests and over-the-counter Narcan. It is entirely possible for them to pay for Hep C tests the same way. Or if not, the large pharmacy chains can negotiate an affordable cash price for their customers. The more promoted Hep C screening is, the less stigma associated with it, the more willing people would be to get tested. At the very least, results can be documented in the pharmacy patient profile, education provided, and positive results faxed to the primary care provider. And if the patients have more questions, we are accessible every day. But if you choose to do more than simply screening for Hep C, start with taking just one patient. One patient cured is one less patient able to transmit Hep C. Even if you do not have prescriptive authority under a CDTA, all of the tasks on this list are within our domain. Checking for and monitoring drug interactions, recommending drug changes, initiating PA requests, helping patients with copay assistance, monitoring compliance, and recommending and updating immunizations. Helping just one patient will add back some excitement to your dispensing days. And the best part, we never need to turn away Hep C patients due to non-coverage. MAVERT is covered for all Medicaid patients with no prior auth needed. Charity foundations approve grants over the phone on the spot for Medicare copays. They would even pay for the $5 copay if commercial insurance patients wanted to apply. The early intervention program pays for Hep C meds for HIV patients. And as a last resort, the drug manufacturers have their own foundations to cover uninsured patients. Hep C patients don't have to pay for meds unless they want to. We rose to the occasion when we were asked to determine Paxlovid eligibility in COVID-19 patients. We had to check lab reports for kidney impairment and liver impairment, and we had to evaluate drug interactions. The typical Hep C patient is younger and has fewer medical conditions and drug interactions than the typical Paxlovid patient. As federal and state laws change and our provider status evolves, we should embrace the opportunities to practice at the top of our licenses. Any PCP who has relied on us to prescribe Paxlovid on their behalf would wholeheartedly champion our desire to prescribe Hep C meds for uncomplicated patients. We have proven to be invaluable members of the healthcare team. The first column highlighted here represents the easiest Hep C patient to treat. When you realize it's not that hard to treat the easiest patients, you can start taking more characteristics from the second column. Or don't, just do whatever you feel comfortable with. Do whatever you can to help eliminate Hep C. Action items to make Hep C screening and treatment attractive to pharmacy chains. Insurances should reimburse well for both screening and treatment. Pharmacy directors, especially of large chains with resources, can negotiate great reimbursements from insurances. Large pharmacy chains can do what they do best, roll out campaigns that would be the envy of other states. Next slide.
Thank you so much, Wendy. And thank you for our other panelists as well. My name is Nick Locke. I use he, him pronouns, and I'm the Director of Research and Best Practice at the Foundation for Healthcare Quality. And it has been my privilege to facilitate some of our BRE topic-specific work groups like this one. I would now like to invite all of our panelists from today to turn back on their cameras and join me as we go through our Q&A process. As a reminder to all of those of you in attendance, you can enter your questions for our panelists under the Q&A box in the toolbar below this screen. You could also enter questions in chat, but we would be less likely to see them. But as we begin and wait for some questions from audience members, I do have a question that I'd like to start out with for all of you. First, thank you so much for participating on our BRE work groups throughout last year and for working towards developing this recommendation. Now that we've completed the hepatitis C elimination recommendations, what aspect of this recommendation and report are you most proud of? Or I guess also most excited about? But yes, Judith?
I can start. Very proud that the recommendations are really thinking about patients and what patients need and what patients want. So I think we started with a very patient-centered approach and also thinking about disparities that exist and how to close the gap on those disparities. So sort of getting back to that patient vignette that I started with, what can we do to help that specific patients and other patients like that get treated?
Thank you, Judith. Would anybody else like to chime in on this question?
I would just add, I'm really pleased that the recommendations are complementary to the work that's already been done, but really take the conversation to some new areas and a focus. So thinking about quality measures in particular, I think having some systemic ways of improving services and building and things like value-based payments. I see a lot of promise with those recommendations, and they're really complementary to the Hep C Free Washington conversations, but not duplicative of. So I think it takes us down a new road of exploration that could have the potential to really create systems change, while at the same time, to Judith's point, really focusing on how through both the public health system and healthcare delivery systems do we create programs, services that are really meeting people's needs and meeting people where they are, both literally and figuratively. So I think I'm most pleased about that.
Thank you, Emalie. I'm seeing we have a few questions being entered in our Q&A. So to move to one of our questions from the audience, Chris writes, are there any larger efforts to help with linkage to care? For example, we are working to get emergency departments to screen patients for Hep C more often, but many emergency departments are reluctant without the resources to help link people to care if they test positive. So this question sounds like it might be more targeted to either Emalie or John, but Judith, if you have any experience from UW's perspective, that could be interesting.
I think the limiting factor has consistently been resources that are for hepatitis C. We are looking in our office at some opportunities for how to take a more syndemic approach, or an approach where we're looking at integrated epidemics or interwoven epidemics. So as we look at the resources our office has for things like HIV and STI linkage to care, can we embed hepatitis C in that approach and sort of and create some opportunities for linkage to care resources in specific. John and I talk a lot about, if we had more money, we would invest all of it in linkage to care for Hep C, because that's really where the need is greatest, is that separation between knowing you have Hep C and getting to a provider who's willing to treat you and take care of your health around hepatitis C. So it is a challenge throughout the state. It is an area we are really looking at how we can be creative in braiding funding in a different way, and also looking at some potential new resources as well. For example, the state, the settlements around the opioid distributors and other opioid related settlements may offer an opportunity to think about how to embed linkage to care services in places like syringe service programs or opioid treatment programs and other settings like EDs. So we're hopeful that some new resources will be brought to bear in the coming year or two. We obviously can't read the tea leaves on that, but we're hopeful. So I don't know, John, Judith, anything to add?
Yeah, ER settings are always really challenging, but it's also great access for the populations that we're most interested in. And we have seen examples of ER settings working for Hep C screening and also linkage to care. Most recently, I believe it was in Connecticut. There's a large health system there that had not only incorporated Hep C screening within their ER setting, but also ensured those individuals were linked to care while they had them there. And what always is something that helps immensely, and always something that is something that's also kind of challenging to do, is that there actually wasn't any new resources that went into that project. It was just the clinical director decided he wanted to do this. And so basically what it was the standard care practice within the ER setting. He made those changes happen. So there was utilizing existing staff to actually pull that off. And so oftentimes the champion model is something that we look to, is something that usually works very well. It's very hard to replicate oftentimes, but it's absolutely doable. But resources are always going to be a challenge. But I thought that was an interesting way of actually tackling what a program could look like within an ER setting, utilizing existing resources. And that just really just came down to one doc who really wanted to make this happen. So.
Yeah, I can add that at the University of Washington, there have been clinicians and researchers who have pioneered some programs through external grants to do systematic screening in the emergency department at Harborview, and also have had piloted using navigators to help link patients to treatment. I think the linkage part is still very challenging, and being on sort of the receiving end of, as a provider, sometimes would get those emails from a navigator. That is always the hard part, is sort of how do we then make it possible to have that patient seen and started on treatment as quickly as possible.
Yeah, thank you all for those resources and perspectives. Just to add as well, I know when we were working through the work group, we worked with the Hepatitis Education Project, which is a community organization of people who have been treated with hepatitis C, and they've done some work to develop a medical case management toolkit, which can be a good resource if you're looking for additional linkage to care resources. Our next question comes from Mark Murphy, and this is a specific question for clinicians. Do you still order reflexive genotype? And I will try to decipher this here. If Hep C antibody and RNA tests are positive, given the availability of pan-genotypic treatments, is this still necessary?
So I can take that. I mean, the newest simplified guidelines from IDSA, ASLD don't include genotype as one of the sort of prerequisite pretreatment labs anymore because of what you pointed out, that the medications we have are pan-genotypic. I mean, I will say that as somebody who's done Hep C treatment for a long time, it can be really hard to sort of rid myself of old habits. And, you know, and there are some contexts where it can be helpful to have a genotype, in particular, if you have a patient who, say, is actively injecting drugs. It can be helpful later to differentiate whether a patient failed treatment or was reinfected if there's a genotype switch. So I think the answer is it sort of depends on the context, but certainly the guidelines no longer include that as sort of a requirement.
Thank you, Judith. I see that we're nearing the end of our time, so I just want to ask one more question and open it up to all of our panelists here. Now that the report has been finalized and sent out, what do you note is the most significant barrier to implementing the report and recommendations, and how might you address those barriers in your setting?
I know for public health, thinking about what care coordination looks like, particularly within high impact settings like syringe service programs or maybe opioid treatment programs. That's the one I'm most excited about, but I'm also knowing and understanding that resources are really needed to hire people and to make sure that they get the right people there. Care coordination is something that Emalie and I often talk about, and how to actually really expand what's currently being done and in most cases not being done. So I think that's going to be one of the more challenging recommendations to pull off. But I'm really also excited about it as well. And I think that's going to be very resource dependent.
I also think that the biggest barrier is lack of resources. But I think, with this BRIE recommendation, hopefully this will make, Hep C given more attention, like COVID-19 was and how HIV was. And hopefully that will open up more opportunities for our stakeholders to give us some of the resources that we so badly need.
Yeah, thank you, John and Wendy. And thank you to all of our speakers for being with us today. I think it's a really important topic to highlight, that we do have the momentum and the energy around eliminating Hep C. And it's really about getting engagement from all of you who have been working in this and all of our attendees today. So thank you for presenting, and then thank you to our attendees. As a reminder, we will have one more webinar on our BRIE topics from 2022. We are currently planning a spotlight on our pediatric asthma recommendation to be held sometime in February of this year. And then we are also planning a health equity webinar series in partnership with the Washington Health Alliance, as well as CoMagin. So please keep an eye out for those upcoming events that I'm sure we will be emailing out to all of you. Additionally, we are currently planning for our 2023 work groups, which include difficult to discharge, diabetes care, and maternal mental health. If anybody on the call today is interested in participating in a future BRIE work group, please feel free to reach out to me. I believe that my email will be entered in the chat. I can put that there for all of you. And hopefully we'll be able to continue to work through some of the pressing healthcare issues in our state. But thank you again for attending. I see we are at time, and I hope to see you at a future BRIE event as well.